Occupational English Test. Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information that you hear. Now, look at the notes for Extract 1. Extract 1, questions 1 to 12. For questions 1 to 12, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Good morning. I see from your chart that there are several issues we need to address today, including your medication refills and the pain in your legs. How have you been feeling overall?
Honestly, doctor, it's been rough. I ran out of my blood pressure medications last week, and I've been feeling this constant headache and dizziness. It's stressful because I know how important it is to keep my blood pressure under control.
I understand that must be worrying. We'll definitely get those refills sorted out today. You mentioned leg pain as well. Can you tell me more about that?
Yeah, the pain starts when I walk more than a few blocks. It feels like a cramping in my calves. If I stop and rest for a few minutes, it goes away, but it's really limiting my activity. This started about a year ago and seems to be getting worse.
It sounds like it could be related to peripheral artery disease, especially with your history. We'll need to reevaluate that. Have you noticed any changes in your weight or diet that might be impacting your health?
I've actually been trying to lose weight. I joined the MOVE program last month for that, but it's been hard to exercise because of the leg pain. I've also tried to cut down on smoking, aiming to quit, but it's been a challenge.
It's good to hear you're making efforts to improve your health. Quitting smoking is tough, but it's crucial, especially for your cardiovascular health. We can discuss support options for that too. Now about your diabetes management. How have you been managing your diet and medication?
I've been pretty consistent with my diabetes medications and checking my blood sugar. It's generally around 125 and 130 milligrams per tier, which I think is okay. But I do worry about running low on my insulin, especially since I'm using it regularly.
Keeping a stable blood glucose is excellent. We'll make sure you don't run out of insulin. How about your cholesterol medication? I see there's been a delay with the mail.
That's right. It's been delayed, and I'm worried because I haven't taken it for over a week now. I'm concerned about my cholesterol levels getting out of hand.
We'll provide some interim pills today to cover you until your supply arrives. Have you been experiencing any other symptoms like chest pain or shortness of breath?
No, nothing like that, thankfully. But I know I need to get more serious about my health. I'm turning 50, and with my conditions, I don't want to take any risks. That's why I'm also thinking about the screenings you mentioned last time, like the colonoscopy.
That's a wise decision. Preventive screenings are vital. We'll schedule your colonoscopy and an eye exam to monitor for any diabetes-related complications. Since it's been a while, it's crucial we check everything.
I appreciate that. I also wanted to ask about something for my cardiovascular health. My friend mentioned low-dose aspirin. Is that something I should consider?
Given your risk factors, it might be beneficial, but let's discuss this after we review your lab results and current status in detail.
Based on today's assessment and your ongoing conditions, here's the plan. We'll refill your medications immediately and ensure you have a sufficient supply of insulin and syringes. I'll order a repeat Doppler ultrasound to assess the progression of your peripheral artery disease, given your symptoms. We'll schedule the preventive screenings, a colonoscopy, and an eye exam. I recommend starting low-dose aspirin daily to help with cardiovascular risk management. Let's also plan a quick follow-up visit to review your upcoming lab results and adjust your treatment plan as needed. Do you have any questions or additional concerns we haven't addressed yet?
No, that covers everything. Thanks for helping me manage all these things. It can be overwhelming at times.
I understand, and I'm here to help you through it. We'll make sure you have all the support and resources you need. See you at the follow-up, and please don't hesitate to call if you have any concerns before then.
Extract 2, questions 13 to 24. For questions 13 to 24, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Good morning. How have you been feeling since our last meeting?
Hello, doctor. I've been okay, but there are a few things that have been bothering me, especially about my blood pressure and this hernia I mentioned to you before.
Let's start with your blood pressure. How have you been managing with the medications?
I've been taking hydrochlorothiazide and lisinopril as prescribed. However, I sometimes feel a bit dizzy in the mornings. I'm not sure if it's the medication or just general fatigue.
Dizziness can be a side effect of these medications, especially when you first start taking them or if the dose is increased. Have you noticed any other symptoms?
Not really, just the occasional headache. But I'm more concerned about this hernia. It started after I did some heavy lifting during the holidays. It's not painful, but it makes some noises, which is a bit unsettling.
Hernias can indeed produce sounds due to the movement of air and fluid in the intestines, especially if there's a bulge in the abdominal wall. Have you noticed any bulging or swelling in that area?
Yes, there's a visible bulge, and it becomes more noticeable when I stand up or lift something. It hasn't been painful, but I am worried it could get worse.
It's good that it's not causing pain, but we should keep an eye on it. Elective surgery might be an option if it becomes bothersome or begins to affect your daily activities.
I'd like to avoid surgery if possible. I'm also a bit wary about hospitals after the pandemic.
That's a valid concern. We can discuss non-surgical options and monitoring for now. Moving on to your vaccinations, I see you agreed to the DTaP vaccine today.
Yes, I trust your judgment. I had my doubts about vaccines in the past, but I understand the importance of staying protected.
That's wise. Vaccines are crucial for preventing serious diseases. Now tell me about your lifestyle recently. Any changes in diet or exercise?
I've gained some weight this past year. I haven't been very active, and my diet hasn't been the best. It's been challenging to stay motivated.
Weight management is crucial, especially for blood pressure and overall heart health. We should work on a plan to improve your diet and increase physical activity. What's your current daily routine like?
I mostly stay at home, do some gardening, and watch TV. I haven't been going out much.
Starting with small steps like walking or light gardening more regularly can be beneficial. Also, adjusting your diet to include more fruits, vegetables, and less sodium will help with your blood pressure.
I'll try that. I know I need to make some changes.
Great. Now let's go over your recent lab results. Your blood pressure today is 4289 millimeter-hergrams, which is a bit high. Your heart rate is stable at 78 BPM, and your respiratory rate is normal at 16 breaths per minute.
What about my cholesterol and kidney function?
Your total cholesterol is 190 milligram bur, which is within the target range thanks to the simvastatin. However, your kidney function shows some decline, with a creatinine of 1.4 milligrams and an eGFR of 59 milli per min. We need to continue monitoring that closely.
I understand. Is there anything else I should be doing?
Just continue with the current medications and lifestyle changes we discussed. I also recommend a colonoscopy this year due to your history of polyps.
Okay, I'll schedule that. Thank you for going over everything with me.
You're welcome. We'll schedule a follow-up in a year. But if anything changes or you have concerns, don't hesitate to contact us earlier. Let's keep a close eye on the hernia and your blood pressure.
Will do. Thanks again, doctor.
Take care and see you next time. Remember, small lifestyle changes can make a big difference.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25.
Okay, so here's the status on Mr. Daniels in room 402. He was admitted last night with severe chest pain and shortness of breath. His current diagnosis is acute myocardial infarction. We've initiated IV nitroglycerin and he's also on a heparin drip. His last set of vitals were somewhat unstable. BP was 90/60, heart rate fluctuating between 88 and 100. I've just redone his ECG and am waiting for the latest readings. He's also been quite anxious, asking lots of questions about his condition.
Got it. Has his family been informed?
Yes, his wife and daughter are currently in the waiting area. Dr. Stevens updated them about an hour ago. Make sure to monitor his vitals every 15 minutes and watch for any arrhythmias. The night team is already alerted about the potential need for further interventions if he doesn't stabilize. Also, keep an eye on his IV lines for any signs of infection or blockage, and ensure the nitroglycerin dosage is adjusted as needed based on his blood pressure.
Understood. I'll keep a close eye on the ECG updates and his overall responsiveness. Thanks for the thorough handover.
Now look at question 26.
Good morning, team. Today we are starting a new protocol for managing septic shock that aligns with the latest research findings. The key point here is the early administration of antibiotics within the first hour of diagnosis. Studies have shown this can significantly reduce mortality rates. We'll also integrate more aggressive fluid resuscitation using lactate clearance as a guide to tailor our approach for each patient.
Are there changes to the vasopressor usage as well?
Yes, we're adjusting our first-line vasopressor to norepinephrine, with vasopressin as a secondary option. Additionally, we're incorporating continuous monitoring of central venous pressure to better manage fluid therapy. This should help us optimize cardiac output and avoid fluid overload, which is crucial for these patients. Ensure that all patient care records are updated in real time to reflect these changes, and educate the patient and family about what to expect during treatment.
Now look at question 27.
Based on your recent symptoms and test results, we're looking at a few treatment options for your rheumatoid arthritis. The first is starting a low-dose corticosteroid to help reduce inflammation quickly. Additionally, I recommend a disease-modifying anti-rheumatic drug like methotrexate, which has a good track record for managing symptoms long-term.
What about side effects? I'm worried about the impact of these medications.
That's a valid concern. Corticosteroids can have side effects like increased appetite, mood changes, and, over long periods, bone thinning. Methotrexate can affect your liver and blood counts, so we will monitor you closely with regular blood tests. It's about finding the right balance between managing your symptoms and minimizing side effects. We'll also look into supplemental therapies, such as physical therapy, to help maintain your joint function and overall mobility.
Now look at question 28.
This new infusion pump isn't just an upgrade for ease of use. It's also designed to reduce medication errors significantly. Let's start with how to set it up. Always double-check the medication name and concentration on the screen matches the patient's chart. Now for loading the medication cartridge, ensure that the barcode matches the one you've just checked.
What's the protocol if there's a mismatch in the barcode readings?
Great question. If there's a discrepancy, you need to halt the setup and verify everything manually again. Remember, this pump has a triple check system. It's programmed to minimize human error, but always keep a keen eye on alerts and follow the built-in protocols. After setup, perform a final verification with another nurse to ensure all settings are correct before starting the infusion.
Now look at question 29.
We have a 54-year-old male found unconscious at home with a suspected overdose. We've administered naloxone en route, and he's now semi-conscious but disoriented. His respiratory rate was low on scene, about 8 breaths per minute, but it's now up to 12. We've also started him on oxygen, and his saturation is improving.
Any known history of drug use or medications found on site?
Family mentioned he has a history of opioid use, though they thought he had stopped. We found prescription bottles for oxycodone and diazepam at the scene. It's critical we monitor him closely for any potential respiratory or cardiac complications as the effects of the naloxone wear off and ensure a smooth transition to the ED staff for further care.
Now look at question 30.
Your stress test results indicate some abnormalities in how your heart responds to exercise. Specifically, there was a noticeable decrease in blood flow to the heart muscle at peak exercise, which suggests the presence of coronary artery disease. Given these findings, I recommend we proceed with a coronary angiography to get a detailed look at your heart's arteries.
What exactly will that procedure tell us?
It'll provide us with clear images of your coronary arteries to see if and where there are blockages or narrowing that could be causing your heart symptoms. Depending on what we find, we can discuss whether you might benefit from stenting or other interventions. This procedure is critical for determining the best course of action to prevent potential heart attacks or other serious cardiovascular events.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1.
Hello everyone, and welcome to today's comprehensive webinar on pericardial diseases, focusing on the intricacies of pericarditis and myocarditis. In this session, we will delve into their pathophysiology, diagnostic challenges, and nuanced management strategies. Additionally, we will explore a case study that illustrates the practical aspects of diagnosing and treating these conditions, referencing recent scholarly articles from Harvard and other esteemed publications. Firstly, let's discuss pericarditis. Pericarditis is an inflammation of the pericardium, the two-layered sac surrounding the heart. This condition can be classified as acute, chronic, or recurrent, depending on the duration and frequency of episodes. The etiology of pericarditis can be diverse. It may be idiopathic, viral, bacterial, or autoimmune, or occur as a secondary complication to myocardial infarction or cardiac surgery. Patients typically present with acute chest pain that is pleuritic in nature, worsened by lying down, and alleviated by sitting forward. The pain is often described as sharp or stabbing. On physical examination, a pericardial friction rub can sometimes be heard, which is a high-pitched, scratchy sound best heard with the diaphragm of the stethoscope at the left lower sternal border. Diagnostic tools include ECG, which commonly shows diffuse ST elevations and PR depressions, and echocardiography, which may reveal a pericardial effusion. Let's consider a case that illustrates these points. A 53-year-old female with no significant past medical history presents to the emergency department with sharp, localized left chest pain that intensifies upon lying back and is relieved somewhat by leaning forward. On examination, a pericardial friction rub is noted. An ECG shows diffuse ST elevation. The echocardiogram confirms the presence of a pericardial effusion without signs of tamponade. This presentation is classic for acute pericarditis. Treatment for acute pericarditis typically involves nonsteroidal anti-inflammatory drugs, NSAIDs, and colchicine to reduce inflammation and prevent recurrence. In some cases, especially those associated with specific etiologies like bacterial infection, additional treatments such as antibiotics or corticosteroids may be necessary. The key to management is not only treating the inflammation, but also monitoring for complications such as cardiac tamponade or constrictive pericarditis. Moving on to myocarditis, this condition involves inflammation of the myocardium and is often more insidious and variable in its presentation than pericarditis. Patients may present with symptoms ranging from mild fatigue and chest discomfort to severe heart failure or arrhythmic manifestations. The etiology is similarly diverse, including viral infections, autoimmune diseases, and toxic exposures. Diagnosis of myocarditis can be challenging. The gold standard for non-invasive diagnosis is cardiac MRI, which can detect myocardial edema and fibrosis indicative of inflammation. However, an endomyocardial biopsy, although more invasive, remains the definitive diagnostic tool, as it allows for histological examination and can guide specific treatments, particularly in fulminant cases, or when specific etiologies such as giant cell myocarditis are suspected. Consider this case study. A 29-year-old male, previously healthy, presents with a 2-week history of increasing shortness of breath and fatigue with associated palpitations. He reports a recent upper respiratory infection. Clinical examination reveals tachycardia and mild jugular venous distension. Laboratory tests show elevated cardiac enzymes, and the ECG exhibits nonspecific ST and T wave changes. An MRI suggests myocardial inflammation consistent with myocarditis. In this scenario, the patient would be managed with heart failure medications if systolic function is impaired, including beta blockers, ACE inhibitors or ARBs, and diuretics. Immunosuppressive therapy may be considered based on biopsy results. This case highlights the need for a high index of suspicion and comprehensive evaluation. Both pericarditis and myocarditis require a diligent approach to diagnosis and management, integrating clinical evaluation with appropriate use of diagnostic imaging and laboratory tests. It's crucial to tailor treatment to the underlying cause and individual patient characteristics to optimize outcomes. As we continue to advance our understanding of these complex entities, ongoing research and clinical trials will hopefully shed more light on optimal diagnostic strategies and therapeutic interventions. I recommend keeping abreast of the latest findings through continuous education and review of current literature, such as articles published in the New England Journal of Medicine and Circulation. Thank you for joining today's session. I hope this discussion enhances your clinical practice and aids in the effective management of patients with pericardial and myocardial diseases. Please feel free to access our educational resources for further reading and updates on upcoming webinars.
Now look at Extract 2. Extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
Welcome to today's healthcare podcast, where we delve into the intricate world of serotonin syndrome, a condition characterized by an excess of serotonin in the central nervous system. Today, we'll discuss its pathophysiology, clinical manifestations, diagnosis, and management strategies through a detailed case study. Let's consider the case of John, a 32-year-old male with a history of chronic depression for whom treatment had recently been switched from sertraline, a selective serotonin reuptake inhibitor, SSRI, to a higher dose of another SSRI, fluoxetine. Additionally, John was taking over-the-counter cough medicine that contained dextromethorphan, a substance with serotonergic properties. This combination precipitated his symptoms. John presented to the emergency department with confusion, agitation, muscle rigidity, and tremors. His sister, who accompanied him, noted that he had been fine until a few days after starting his new medication, when he began to feel restless and sweaty. On examination, John's vital signs included a temperature of 38.7 degrees Celsius, heart rate of 110 beats per minute, and elevated blood pressure. Neurological examination showed myoclonus, hyperreflexia, and ocular clonus, all hallmark signs of serotonin syndrome. Understanding the pathophysiology is crucial. Serotonin syndrome occurs when there is an accumulation of serotonin, typically due to medications that affect serotonin metabolism or serotonin receptor activity. This can include SSRIs, serotonin norepinephrine reuptake inhibitors, tricyclic antidepressants, monoamine oxidase inhibitors, and over-the-counter supplements like St. John's wort. In John's case, the combination of fluoxetine and dextromethorphan significantly increased serotonin levels in his central nervous system, leading to overstimulation of 1A and 2A receptors and resulting in his symptoms. Diagnosing serotonin syndrome can be challenging due to its spectrum of symptoms that can mimic other conditions such as neuroleptic malignant syndrome, anticholinergic toxicity, or meningitis, which may delay the interventions. The Hunter criteria, which we used in John's diagnosis, is a diagnostic tool that includes symptoms such as spontaneous clonus, inducible clonus with agitation or diaphoresis, ocular clonus, tremor, hyperreflexia, hypertonia, and temperature above 38 gross Celsius, along with an increase in serotonin-modulating agents. Management involves immediate discontinuation of all serotonergic agents and supportive care to stabilize the patient. Symptomatic treatment for John included sedation with benzodiazepines to reduce agitation and muscle rigidity. We also aggressively managed his hyperthermia with cooling measures and intravenous fluids to prevent complications like rhabdomyolysis. In severe cases like John's, where there is significant hyperthermia and neuromuscular abnormalities, more specific interventions might be necessary. Cyproheptadine, a serotonin antagonist, can be administered. It acts as a competitive inhibitor at serotonin receptors and can be given orally or through a nasogastric tube in intubated patients. For John, we started cyproheptadine once he was stabilized and closely monitored for improvements. The prognosis of serotonin syndrome varies. Mild cases may resolve within 24 to 72 hours with appropriate treatment, while severe cases can be life-threatening. John's timely arrival at the hospital and the immediate recognition of his symptoms likely prevented more severe outcomes. This case highlights the importance of considering drug interactions as potential culprits in sudden changes in patient status. Healthcare professionals must be vigilant when prescribing medications known to increase serotonin levels, especially when patients are already using other serotonergic drugs. Education on drug interactions and the signs of serotonin syndrome should be a mandatory component of medical training and ongoing professional development. Serotonin syndrome is a complex and potentially life-threatening condition that requires prompt recognition and aggressive treatment. As clinicians, we must maintain a high index of suspicion, particularly in patients presenting with autonomic disturbances, neuromuscular abnormalities, and changes in mental status, especially if they have a history of polypharmacy involving serotonergic agents. Understanding the pharmacological properties of medications and their interactions plays a crucial role in preventing this syndrome. Thank you for joining today's discussion on serotonin syndrome. It's essential for healthcare providers to continuously educate themselves about such conditions to enhance patient safety and improve outcomes.